Hello everybody, my name is Castro. I'm one of the physicians of the Hematology and Bone Marrow Transplant Division here at UCSD. This morning when Laura was saying that she was working with Dr. Phipps for 30 years, I realized that in a blink of an eye, actually I've been working with Tom for 15 years. I moved to San Diego and I came here because I was interested to work in this early and very pioneer work in gene therapy, and I had the fortune to have him as a mentor for this period of time. So thank you so much for coming. I mean, it's great to see a lot of familiar faces, some of those that are probably I'm not too familiar, but overall, we appreciate your help and support, having access to your care, to your samples, is what helped us to develop trials like the one that I'm going to present today. So, as Dr. Phipps mentioned, one of the challenges that we have in CLL are those patients that they don't respond well to therapy, and they are classified as high-risk disease patients. And particularly in that group, we have patients with something that is called a Richter syndrome or Richter's transformation. To give credit to Dr. Richter's, actually, there are very few pictures online. This is probably the most well-known one from Wikipedia. He was a prominent pathologist from New York. And he had actually a couple of descriptions in the literature of different diseases that for the first time were clearly identified. One of them is the transformation of CLL cells into a more aggressive tumor. Richter syndrome, fortunately, is not too common. It happens in about 5 to 10% of the patients, and is characterized by a rapidly progressive disease that includes rapidly growing lymph nodes, the spleen, proliferation of the lymphocytes. And what is challenging is that there are no clear and standard regimens for treatment of patients with Richter's transformation. I hope you can project well that image, but the idea is to show you how in the same tissue we have that translation and transformation from a small, very monotonous and homogeneous cells to the ones more to the right, that they tend to be larger, more aggressive looking, more darker, as you can see in this diagram. So together with Dr. Phipps and Dr. Choi, we put together a clinical trial that we hope that we can expand it to other member centers of the CLL Research Consortium that is based on one of the antibiotics that you just heard, obinutuzumab or Gazyva, in combination with a core structure for program that we have developed for many years that is based on high doses of methylprednisolone. And in addition to that, we included lenalidomide or Revlimid. And for some of those patients that they have available donors, also we are performing either a consolidation with an allogeneic bone marrow transplant or a maintenance regimen. So basically the idea is to incorporate this non-chemotherapy induction treatment based on the steroids, Gazyva, and Revlimid. And after assessing the response of those patients, we, for those that they have an available donor, we propose to take them directly to an allogeneic transplant. But for those that are of advanced age or they have comorbidities, as Dr. Griffin was saying, bone marrow transplantation is not for everyone, to continue the maintenance with lenalidomide or Revlimid. Because an image is worth 1,000 words, I wanted to show you a couple of images of one of our patients treated with this regimen. She's a patient that was diagnosed with CLL. And at some point rapidly in early 2014, she noticed a progression of the disease. One of the characteristics of that was a rapidly growing lymphocytosis, if I can use this one. Yeah, this one. Rapidly growing lymphocytosis, you see the lymphocyte count rising very rapidly to levels of 100,000. And the other characteristic, as we heard from different speakers, later by Dr. Griffin, is that patients with high-risk disease are those that they have genetic abnormalities that involve the chromosome 17. And in this particular case, the patient has 71 of the cells that carry that particular abnormality that we call deletion 17p. So on top of that, one of the tissue samples that we collected showed that transformation, that transfer of the small cells from a small, homogeneous, slow-moving cells to the more aggressive component of cells, the so-called Richter syndrome or Richter's transformation. So this patient has significant amount of risk factors, and for that reason, we proposed to her the treatment that I just mentioned a minute ago. We were fortunate to see that early on, after initiation of the high-dose methylprednisolone in combination with Gazyva and Revlimid, we have this drastic reduction of the lymphocyte count. As Dr. Kipps was preparing, initially this was very concerning to everybody, including our infusion center nurses, but this is what we see when the treatment is effective. That includes one of those antibodies, like Gazyva. And then after 6 cycles of therapy, we proposed to her to do an unrelated donor allogeneic transplant. This was in June of last year, and as you can see, the white blood cell count has been maintained within the normal limits. This is a PET scan. PET scan, for many of you that are familiar, is a technique that is based on an especially labeled sugar that gets accumulated with the tissue, is very active. So as you can see here, this is the imprint of the image, the body image of the patient, and you see that this is not normal. There is a lot of activity in different areas of the body, but particularly in the left axillary region. Some images are the series throughout treatment. This is after 3 cycles of the initial treatment. You see that that very dark and active area has been gradually decreasing, and there is a remnant of the FTE uptake, the specialized sugar, and this is after allogeneic transplant. And right now she's about 10 months after transplantation, and she's doing quite well. So in summary, we have patients that we consider high risk, particularly this group of patients with Richter syndrome. The incorporation of new biological therapies is the one that we've been discussing through the day. Definitely are going to be part of the elements that we would like to incorporate in our new clinical trials. This combination using what we call a non-chemotherapy treatment with high-dose methylprednisolone, Gazyva, Revlimid, in conjunction with an allogeneic transplant, we think that offers potential as a treatment strategy for high-risk patients, including Richter syndrome. And as I was mentioning, I hope we can involve other centers of the CRC in this clinical study. Thank you so much, and I appreciate your time, and I guess at the end we're going to have time for questions. Thank you.